1 minute.
Okay, you can start. Okay, you can start. Okay.
I'm Nada Alavi from Palakkad, graduate from GHMCT 2008 batch, pass out 2015. I would like to present a case female infertility. Patients with age 26, height 156, weight 60 kilogram, BMI 25, BP at present 170, ppbs 120. Patients records uses normal. That time TSH 18.5. When she take a IVF, that time her TSH 18.5 and next November TSH 4.17. The presenting complaint infertility for 18-year hypothyroidism with weight gaining, allergic rhinitis, frequently sneezing in the morning, which cause nasal obstruction. History of presenting complaint 2011. That time she was studying BTech. After 4 years of marriage, they consulted a gynecologist, but no complaint for both. After 4 years of allopathic treatment, they did IVF in 2019, 17 July, but failed. Family history: father diabetic, brother diabetic. History of past illness, urticaria in childhood. Physical generals: aversion to veg, mutton, sore, plus. Frequent urination daytime. Also perspiration on face. Mental generals: anxiety about future. Menstrual history: duration 7 days, cycle 27 to 29 days, nature watery red color, dysmenorrhea absent, leukorrhea absent. Rubrics taken: rubrics: female sterility, general food and food sore aversions, mind anxiety, future about, bladder urination frequent daytime. Repertorial result: natromore 9/4, soreness 6/8. Remaining symptoms എടുത്ത് നാട്രമോർ 1 മാർക്ക് വന്നു. അപ്പോൾ പ്രിസ്ക്രിപ്ഷൻ നാട്രമോർ CM 1 ഡോസ് കൊടുത്തു. പിന്നെ ആഫ്റ്റർ 1 ചെക്കപ്പ് absolute eosinophil count 522, also TSH 9.29 ആയി. 2/5/20 അതായത് ഒരു 6 months
Can you take bit of English?
SCG positive. Okay.
Okay.
Thank
Dr.
you.
Joyce? Okay, that was an excellent presentation, Dr. Nada. Dr. Joyce?
Thank you.
Dr. Joyce? I think it's not there.
Hello. Hello.
Yeah, Dr. Joyce, can you invite the second?
Okay, we have the next participant, Dr. Nirav Ganatra. Dr. Nirav, are you there?
Dr. Nirav, I think the time is running out. So I think he's not there. Can you, who is the next participant?
Okay, we have another participant from Pune, Maharashtra, Dr. Shardul Joshi. Let me try on him. Please, a second. Dr. Deepu, I'll have to contact him once. Please wait, okay?
Okay. Dr. Neerav, are you able to unmute and share now? Can you try once more? Dr. Neerav, I made you both accounts a co-host. No, you can unmute yourself. No problem. You just try once. I just made you a co-host now. Can you try one more time?
Hello, Dr. Deepu.
Yes.
Can you please make Dr. Shardul Joshi co-host?
Shardul Joshi. Yes, I'm trying.
SHAR.
Yeah. Okay.
Okay, he's
Okay, done,
co-host now.
Done.
Okay, now I welcome Dr. Shardul Joshi, a postgraduate homeopath from Pune, Maharashtra. Sir, please, you can start sharing your screen also.
Hello, can you hear me?
Yes.
Okay, so I will share my screen. Okay, so can you see the PPT?
Yes.
So should we start with my case?
Yes, you can start, sir. No problem.
Okay, so thank you, IHA, for giving me this opportunity. And today I'm going to share a acute case. This is the case of acute appendicitis. And this is the case of 7-year-old girl, and she was my old patient, and she was taking treatment for a recurrent cold and coryza. And one day she came with the complaints of pain in abdomen, and that pain in abdomen she was experiencing since 1 week. And in between, her mother gave her some antipyretic or paracetamol medicine for the pain. So pain used to come and used to subside with the medicine. But when she came to me that day and one day before, she had very severe pain. And the pain was in the abdomen, and she used to roll on the ground with the pain. And with that, she had nausea and one episode of vomiting when she came to me on that day. And in that, vomitus contained the ingesta, what she had. And the intensity or the severity of pain was really high, that increased. So mother was worried and she wanted to come and consult to see what is exactly it. The child was not able to tell the exact character of the pain, but she was able to tell where she is getting the pain. Okay, so when I asked her about the pain, she said pain in my abdomen, right? She was not able to locate it exactly, but she was saying I'm having the pain. She was showing by her hand, I'm having the pain in my abdomen. So on the entire abdomen she was showing me, and that the pain was aggravated by fasting. Okay, so actually in this girl, she was taking treatment for recurrent cold and coryza, and her one of the complaint was her appetite was very poor, and that was the concern of mother. But what mother said, when she is having this pain, this abdominal pain, her appetite has been increased, and whenever she gets the pain, that attack of pain, she wants something for eat, and when she eats something, that pain subsides. Okay, so that was a very interesting symptom, I thought. And mother said she's eating since morning. She gets the pain, in pain she wants to eat something. Whenever she eats, her pain subsides, and after 1 or 2 hours again she will feel hungry, and when she is hungry, again pain will start. So this cycle was repeating throughout the day. So that was the characteristic modality, I thought. The pain ameliorated when she is fasting or hungry, and pain getting ameliorated by eating. And as I said, intensity was very high, the pain intensity of pain, and she was rolling on the ground with the pain. So that was the one thing, and mother said this is very strange. Her appetite was never been so high before this. And one more thing mother shared, that she would not like anything around her waist. So she said, please, the pants or the clothes she was wearing, she said, please put it very loose. I cannot bear that. So that is the one thing mother observed and mother told me. So these are the few characteristics I got. With the pain in abdomen and the vomiting, I suspected that there must be something in abdomen and I should check. So when I did the examination, so that time she was not having fever, but she was having severe tenderness in right iliac fossa. So when I got this finding on examination, I suspected this could be the case of appendicitis, acute appendicitis. So I did the further examination. Rebound tenderness was absent. So I was a bit relieved, because as we know, rebound tenderness is a sign of severe appendicitis, that appendicitis is progressing and it is maybe about to burst. So and her vitality was good, she was looking good, she was not toxic. So that is also one of the important thing I observed. So I thought, let's send her for investigation and get her investigated, and then I will start the medicine. Okay, so I told this to mother, I think this could be the appendicitis, so let's have a sonography first and then we'll decide. Okay, then we'll start the medicine. Fortunately, the sonography center, the diagnostic center, is near to my clinic, so I immediately sent her for the investigation, and she came with the sonography. So this is the report of USG abdomen. If you read the impression, that impression says she has acute non-perforated appendicitis. Okay, so she came with this report, and now there was question in front of me whether to accept this case or not, because being a homeopathy, it is always difficult, because homeopathy has been questioned, or the efficacy of homeopathy has been always questioned in the surgical cases. People think that homeopathy is good in functional diseases or psychiatric diseases. So, and sometimes we homeopath also believe that homeopathy has the limitation in surgical cases. So question was there whether to accept this case or not. But this case taught me, if we put a certain criteria, guidelines to accept any case, definitely we can accept the case confidently, because at the end of the day your confidence also matters. So I decided to accept this case on the following reason. First reason was the mother and that child was already taking treatment from me since many years. So mother was having a lot of faith on me. So that is the one reason. Second reason, on examination, she was, as I said, I didn't find rebound tenderness, and her vitality was also stable. She was not toxic. So that is the second reason on the clinical side that I decided to take a chance for this girl. So I took the acute case history, and I prescribed the medicine. I said her to mother, please inform me daily, morning and evening, telephonic follow. So we will be in touch, and anything happens, we could rush to the nearby hospital. So I told that mother, and I gave the medicine. So an interesting thing, though mother was so faithful on homeopathy and she was having faith on me, after going to me, they visited a surgeon also. They visited two surgeons. Both of them said, get admitted immediately. One surgeon said, we have to get operated, right? Surgery is must. So that was that mother told me afterwards when she recovered from this. So this is the case in short. I will share my analysis of this case because the case is acute. Symptomatology was not much. So when I relooked the symptoms, so she was having the abdominal pain, right? The intensity of pain has been increased since 2 days, previous day and today. Not this much intense since a week. And she was having only one episode of vomiting, and nothing I was getting characteristic in the character of vomiting or offensiveness or anything. I was not getting. But in pain, definitely there is something interesting. So first thing struck me was her appetite. The girl who was taking treatment for recurrent cold coryza and poor appetite, her appetite has been increased. And in practice also, what we see when we have some pathology related abdominal viscera, usually our appetite goes down. Appendicitis or acute gastritis, gastroenteritis, colitis, we see appetite goes down. But in this case, her appetite is been increased. So this is something very characteristic, I thought, and my medicine should have this symptom. Without this symptom, I'm not going to prescribe. I was sure for this. So this symptom became anchor or eliminating symptom for me in this case. Being a pathological case, I decided to repertorize through Fatak repertory. As we know, Fatak repertory is very good, handy in bedside prescribing and in pathological cases, because Fatak gives a very well selected, tested and tried few medicines that Fatak or the stalwarts of homeopathy they have tested. So I decided to go for Fatak repertory. So I took the symptom, this appetite increased during pain, appendicitis, and the characteristic modalities: fasting aggravation, eating emulation. Okay. So this was my totality. Are you able to see? Hello?
Yes, sir.
Yeah. Okay. So this was my totality. So I was searching appetite, increased pain in abdomen with, but I got this rubric, very interesting rubric: appetite increased, hunger, pain in stomach with. So we can interchange stomach, abdomen when we are not getting the exact rubric. So I took this rubric. If you see, only 3 medicines are there in this rubric. Then I took fasting aggravation, eating emulsion, and Fatak appendicitis, the pathological rubric. In Fatak repertory, what we do, we took the general rubrics. As we know, Fatak was the follower of Boger, and he believes on the grand generalization. So Fatak gives the general rubrics. So I took this rubric, and lachesis was coming. Okay. So when we go, when we see lachesis, phosphorus, sepia, plummen, but the lachesis was the only medicine covering the 4 rubrics. When we go back to the case, what we see, mother's observation that child would not like even clothes touching her abdomen. She would say, don't tie the pant tightly. I don't like this. Don't tie anything around my waist. So that was very characteristic.
Dr. Shardul Joshi, you have 3 more minutes. Okay.
Yeah. Almost finished. So this was the characteristic observation, and that led me to the thought of giving lachesis. So I was thinking of giving lachesis. I took the reference from Materia Medica. If you see Fatak's Materia Medica, so in Fatak's Materia Medica, if you read the generality chapter of paragraph of the lachesis, so it says the highlighted portion you can read excessive sensitiveness of the surface with intolerance to touch or constriction. So that was that is the hallmark of lachesis. With that, there is intense nervous irritability, restless, tossing and moving. So in pain, what mother said, she was rolling on the abdomen. So that moving, tossing, rolling also getting covered. That touch sensitivity is also getting covered. And if you see in abdomen in particular, so cannot bear anything around the waist is given, and in italics appendicitis. So Fatak or Boric, all these are the clinical materia medica. They gives you direct diagnosis. So Fatak has mentioned in italics appendicitis in lachesis. So I was very sure while prescribing the lachesis. So I gave her lachesis 30 4 hourly. So after when I prescribed the same day, next day I took the follow. So next day pain was much relieved. So I was also relieved that she is responding to lachesis. So I continued the lachesis. Slowly her pain reduced. She didn't have fever, she didn't have vomiting, and she improved day by day. Within a week, she was completely out of this. And again, we sent her for investigation. We did her sonography again. So you can read the impression that findings are suggestive of resolution of appendicitis. So appendicitis completely resolved, and mother was very happy. Obviously, child was also happy. And I have the video of testimonial of this patient. And mother said it is hard to believe that she has the appendicitis, and doctor surgeon asked to the hospitalize, get operated, but she relieved with only homeopathic medicine. So mother was also very grateful, and the credit goes to the homeopathy and Master Hahnemann. So this is the message I want to give from this short case is believe in yourself, believe in homeopathy. If you have confidence in you and in our science, you can convince anybody for any case. Okay. Thank you very much. Thanks again, IHMA, for giving me this opportunity. If anybody has any question, quickly I can answer. I would like to answer any question.
Okay, thank you, Dr. Nero. The presentation was clean and convincing. Thank you for this detailed and explanatory session. So if there is any doubt regarding this, you can just drop your message in chat box. We are running out of time for the next section. That is why we are currently moving to the next session. Dr. Deebu?
We have another presentation that will be after the class. Okay. Dr. Amsal, are you there?
Yeah.
You can moderate.
Can you hear me? Okay. Good evening, doctors. Today we have a session by Dr. Abdu Rahman. Due to some technical glitches, we couldn't complete it last time. So we are starting it from the beginning itself. Welcome to the seminar. I think Dr. Abdu Rahman is there. Hello?
Yes. Good afternoon. Hello? Are you hearing? Hello?
Yeah, we can hear you. We can hear you, sir. We can hear you.
You are hearing. Okay.
Yeah.
Can we start?
You can start. You can start the presentation. Okay.
Yeah. Dr. Abdu Rahman, can you hear me?
Yes, certainly. Yes, I am hearing.
Okay.
Hope
You can start the
wrong.
session.
Okay.
Fine.
Okay. Good evening, doctors. I'm here to present the postponed session. It was scheduled a few days ago, but due to some technical issues, we couldn't complete the session. And now, the topics we are going to discuss today here is a part of the emergency medical care program. Yes, in this topic, we will discuss two topics. One is the essentials of catheterization, and the another is nebulization. Okay. It's a topic, it's a part of emergency medical care program. We have scheduled this program exclusively for the homeopathic doctors, where the homeopathic doctors are failing. It is actually not in the case of therapeutics. We have a good tool of therapeutics, that is our materia medica and a philosophy, repertory, etc. Even after we have a good tool of therapeutics and a good weapon to deal with the any type of diseases, even after that, there are a number of failures in our system. To address some of the failures, we can, in the experience of many doctors, what is the failure is not actually their lack of knowledge in therapeutics. Instead, in the other management, accessory management system. For example, urinary catheterization that we are going to discuss. Another topic is nebulization, and another topic is injections. In the type of injections, we are not going to study the details of injections, but we should know something about the basics of injections. Even the laymen know many of the injections. Suppose our hospitals, suppose we are working in a hospital, in RMO, or a doctor in a hospital, then there will be a patient. A number of patients are there. Some patients will be having diabetes mellitus and may be taking insulin injections. There are a number of questions from the part of the patients. What are the when we have to take the injection, and how the vials can be, the injection, the insulin vials, how long it can be kept, and etc. and etc. And such questions will be arising. That we should know something the basic injection. Another topic is IV infusion. There are a number of occasions in a hospital where IV infusion is inevitable. Or suppose
Your screen share is off now.
what?
Can you share the screen now?
Screen sharing, has I not started the screen sharing?
Okay, no problem. Okay. Fine.
Okay, this is just an introduction. And likewise, suppose there's a hyponatremia, the patient is having an hyponatremia. In the case of hyponatremia, it is not to it cannot be dealt in acute conditions with a medicine. Instead, it needs, if the patient is not orally taking orally anything, then we have to supplement in parenterally. Then IV infusion will be very inevitable in certain conditions, especially in the case of carcinomatous patients, or especially the esophageal carcinoma. So the patient will not be able to take anything orally. And the topic is nasogastric infusion. There's a Riles tube infusion. There are a number of patients in our hospital where they come with the Riles tube, but from the allopathic system. But after our medicines, we can remove the nasogastric tube, that is Riles tube. That is usually seen in our hospitals. Another topic is regarding this is suctioning, then oxygen therapy, death. Many of the doctors are very reluctant to confirm a death because there are a number of anxieties regarding this, and CPR, palliative care, first aid, etc. In this field, if we are able to tackle these conditions also, then we can have a good rapport with the patient, and we can give a good relief to the patient. That is the we are doing in this case. That is in this emergency medical care program. As a part of this, we are going to deal first with the urinary catheterization. Are you visible this slide? Hello, are you visible?
Yeah, it's visible.
Okay. Then catheterization. The catheter means a tube. The catheterization means the introduction of a tube into the urinary bladder through the urethra. That process is known as catheterization. That we all know, but it is a sterile medical procedure, a strict sterile medical procedure, because no organism should enter the urinary tract during the procedure. That's why it is not a strict sterile medical procedure. And so Before we going to the procedures of catheters, there are three types of urinary catheters are available. One is indwelling catheter or the Foly's catheter. Indwelling means it is retained inside the urinary tract, inside the body. That is why it is known as indwelling catheter. It is known as Foly's catheter. Then another catheter is intermittent catheter or Robinson's catheter. Each one will discuss later. Another is condom catheter or Texas catheter. These are three types of catheters. Then regarding the first one, Foly's catheter. Foly's catheters have two types. One is rubber catheter, another is silicone catheter. We'll discuss the rubber catheter first. It is made of latex rubber. Then there are size. We should know the size of a, not the size of the lumen. 6 to 26 French size. And when we say it is 6 to 26, 6 is very small. And as we go to the higher size, the thickness, the lumen increases in size. That's why the adult uses higher sizes. Then one French size means 0.33 mm in the circumference. Then how long a catheter can be retained in the body? We should know about this. Change in a maximum of 4 weeks or within a month. It should be retained only it can be retained up to 1 month. After 1 month, it should be removed. There are some complications. If we have to expect that, we will discuss later what are the complications of that. Then types of, we have discussed that Foly's catheters. Foly's rubber catheter itself is of two types. One is two-way and the another is three-way. Two-way rubber catheter and three-way rubber catheter. That all we should know as a physician, because when we give a direction, a prescription to avail these things, we should know what is the catheter. If we are mentioning only Foly's catheter, the medical shop cannot issue a catheter. We should write down Foly's catheter, so and so the sizes should be mentioned. If you are giving only a direction Foly's catheter, they will give two-way Foly's catheter. Then this two-way Foly's catheter has got a head is there, a tube is there, and a tail part is there. The head part has got two bifurcations. One is with a covering and the other is straight. This is with a diversion and this is the straight. This straight part, this is the urine port through which urine comes out. The another part, it is the inflation port or balloon port, inflation port, through which we have to inflate the balloon. Then that is the urine port, then inflation or balloon port. These are the two ports in the head part of a catheter. Then in the tail part, there is a bladder opening and a balloon, a bladder opening and a balloon. The balloon can be inflated. Suppose we are inflating it, then the balloon can be inflated. Is it visible? Okay. The balloon can be inflated. Then these are the parts of a Foly's catheter. The head part is there. The head part has got a straight part. The straight part is the urine port through which urine comes out. Then another part is the inflation part or the balloon part through which we have to inflate this balloon. Okay. Then there is another catheter, rubber catheter, that is three-way catheter. This we have discussed. This is the straight part, that is the urine port. This with the covering, that is the inflation port. In addition to these two ports, this three-way catheter has got another port, that is the irrigation port. Urine port, inflation or balloon port, the tail end has got bladder opening and a balloon and irrigation port. In addition to the others, it has got an irrigation port also. This irrigation port is intended to irrigate the vesical region or the bladder irrigation or bladder wash. There are certain occasions, especially in the allopathic hospital, in the severe cystitis. What they are doing is that they are passing normal saline added with betadine solution. 500 ml of normal saline is there. Some amount of betadine solution is added, and then this IV line, that's IV line, is introduced into the irrigation port. That then what happened is this goes inside the bladder, and through the urinary opening, it enters this tube and goes out of the urine port. Then what happens is the bladder is washed, bladder irrigated. Instead of adding this type of antiseptic or antimicrobial agents, we can use our own medications, whether tincture or indicated medications, in this bladder irrigate during the irrigation. And these are the part of a three-way rubber catheter. Then the size of three-way rubber catheter varies from 22 to 26 French size. If you want, if we are intending a bladder wash also, suppose the patient is very bedridden for a long period and there is a recurrent cystitis, and then we have to expect this type of, we should introduce a three-way rubber catheter. While we are giving a direction for a three-way rubber catheter, we should bear in mind that it is available in 22 to 26 French size only, whereas in the case of another catheters, it is available from 6 to 26 sizes. The difference should be remembered. Then another type of catheter is known as silicon Foly's catheter. Silicon Foly's catheter, it has got some advantages above the other rubber catheter. The advantages, there are two-way, and this two-way rubber catheter, two-way silicon catheter, size is 8 to 26 available. Three-way, the size 16 to 26 silicon catheter are available. There are some advantages of silicon catheter over the rubber catheter. The advantages is that one is it is less prone to injury and infection. Less prone to injury and infection. But in the case of a rubber catheter, this is it is made up of latex rubber, and so there is a possibility of damage. And then another peculiarity is less irritant to urinary mucosa. It is very inert material. The silicon catheter is very inert material, and it do not cause any irritation to urinary mucosa. More resistant chemical changes and temperature changes. That's another advantage of the silicon catheter. And also another peculiarity is that in the case of a Foly's rubber catheter, it is not, the balloon do not expand symmetrically. But in the case of a silicon catheter, the balloon expands symmetrically to all directions. That is another advantage of this silicon Foly's catheter. Okay. Then the most important advantage is that it can retain up to 6 months, whereas in the case of rubber catheter, it should be removed within 1 month. If the patient is for a long period bedridden patient, then it is better to use a silicon Foly's catheter, because the patient, there is no risk of frequent changes of rubber catheters. And that is regarding the different types of catheters. Now we'll go to the catheterization. After it is introduced into the urinary tract, it is the urine comes out of the urine port, and it should be connected with urobag. There are 3 types of urobag. One is down drain, that we usually see in the hospital. The urobag is tied to the legs of the cot, and this is the urobag, and it can collect up to 2 liters of urine. 2 liters is marked, and it is known as down drain. It is the usual. When we give a direction, for a urobag, suppose we are the patient is using the first for the first time, then we are directing to get a Foly catheter with urobag. Then it will be provided. This urobag will be provided. Another urobag is that leg bag. It can be tied to the thigh of the individual, and it is ambulatory. The patient go as in his own way, and that is another type of urobag. Another type is the belly bag. Then in this case of a belly bag, it can be tied to the abdomen, and so it is very useful. The patient is more ambulatory. No one knows that he is he is catheterized, and that is this belly bag. Usually we use in a hospital the down drain. When we give a direction for a urobag, what is provided is this down drain is the provided, the first urobag. Then we come to the indication. When urinary catheterization is indicated, there are a number of conditions. One is acute and chronic renal retention of urine. That is the most important indication for the introduction of a catheter. We have a number of medicines in allopathic hospitals. They usually do a catheterization, but the catheterization, urinary catheterization, is not the first option in the acute or chronic urinary retention, because there are a number of complications waiting after a urinary catheterization, and so it should be it should be adopted as a last resort. First, what we are doing in a retention of urine. Have you ever seen a patient having a urinary retention? If you are able to witness a patient with a urinary retention, the agonizing pain and the agonizing dilemma or the agonizing situation of the patient is a very pathetic condition if the urine is retained inside the bladder. In such conditions, the first option is not the introduction of a urinary catheter. Instead, we can apply hot and cold water bags. Alternate application of heat and cold water. Suppose we have a hot water bag. Inside a hot water, it is, if hot water bag is not available, we can have a glass bottle, a large glass bottle. In one bottle we can take hot water, and another bottle we can take cold water, and then it is applied over the abdomen in the hypogastrium, in the hypochondrium or in the pubic region. First we apply hot water bag or hot water, and then apply the cold water. Alternate application of heat and cold. Sometimes the urine may escape. If even after that the patient is not getting any relief, another option is that if there is a bathroom, open the tap. The sound of the running water may induce automatically in the patient to void. That also may be adapted. Even after this, we are unable to, the patient is unable to void urine, then retention, catheterization can be adopted. Another situation is benign prostatic hypertrophy. We have wonderful medicines for that. Then incontinence of urine, another indication of for. Then before surgery, many the patient will be under anesthesia, and during anesthesia the patient will not be able to normal urination, and so before surgery it is indicated. Then diagnostic purposes. These are the indications for a urinary catheterization. Then before we go to urinary catheterization, we should have some prerequisites. Only after that, especially in the case of in a hospital, or we are the authorized person to do the process. Or sometimes it may be in our house or in premises, or we are called for a procedure. Then we should know what are the requisites. What first requisite? You should have a tray with a sterile catheter of required size. We should know the required size of the patient. Usually 12 to 18 sizes are in the case of a adult. Usually 14 or 16 size is usually required. It should be sterile and it should be within the expiry date. You should not have passed the expiry date. Whenever we get something like this catheter from a medical shop, especially in the allopathic system, the medical shop, we should look for the expiry date. It should be within the expiry date and it should be intact and sterile catheter of required size. This is the first one. Another thing we should have with our hand is a lubricant. Usually xylocaine gel or lignocaine gel or lidocaine gel, these are the names of this gel. Actually it is lignocaine hydrochloride. This is the lignocaine gel. It is a lubricant as well as a local anesthetic, and it should be in hand before we going to a catheterization. Another thing is that an antiseptic solution, a Dettol solution or something like that, should be in hand. And third, kidney tray, cotton swab, gloves, etc. should be in hand. Then scissors, forceps, syringe and water. When we are going to the procedure, we will clearly know what are the necessities of this accessory measures. Then procedure. Suppose nothing to tell about the hand washing. Even in the COVID period, we are well aware of the importance of hand washing. Then hand washing is very important in a proper way. It is not a usual hand washing, but instead a 20-second long hand washing with rubbing with a sanitizer, with a soap water or with a lotion, hand washing lotion, etc. Hand washing, proper hand washing. Then provide privacy during the procedure. It's a very important measure we should adopt in every procedure like this, because the individuality and the personality of the patient should be given due importance. And so provide privacy during the procedure. No unwanted person should be allowed to approach the patient. And so if the screen is possible, or if in a room it is possible, whatever it may be the measures, we should give enough privacy to the patient. Then locate the opening. In males, it is not much difficult to locate the opening. But if there is epispadiasis or hypospadiasis, we should be careful if there is anything like that. But in the case of a female, to locate the opening is a little difficult. Because to overcome that, then what is the procedure to be adopted is with our the thumb and the forefinger, press beyond the labia majora and the superior part, press and raise. If we are able to press and raise beyond the labia majora, then we can clearly see the upper part. We can see the urethral opening, then the vaginal opening. It can be clearly seen. Then locate the opening is very important. Then clean around urethral opening. It should be cleaned with a swab, with a cotton swab. A cotton swab is taken in a with a forceps. This is a forceps. Everyone know. This is an artery forceps. This is another forceps. This is another forceps. This is known as dissecting forceps. This is artery forceps, and this is dissecting forceps. Then we are using this artery forceps for this type of procedures. Take a cotton swab, and it is taken in the with the forceps, and this is dipped in the antiseptic lotion, and it is squeezed on the walls of the vessel in order to avoid the spilling of the excess lotion, and then clean around the urethral opening. Okay. Then lubricate. Lubricate the opening, lubricate the urethral, first part of the urethra, and we can lubricate the tail part of the catheter tube also. That also can be, the tail part of the catheter tube also can be applied. Some lubricant can be applied to tail part of the catheter also. Then connect the catheter with the urobag. The catheter, we have already told that the catheter has got a urine port. The urine port is connected to the urobag. This is urobag. Okay. Then a gentle insertion. During the first part of the insertion, there will be some hindrance, some sort of resistance. But as it has entered the urethral opening, then it will go smoothly. Before the procedure, we should know that the patient's cooperation should be first addressed. Because before the procedure, we should give a small directions. We should give a small introduction about the procedure we are going to do, and we should be able to convince the patient that it is for the relief of the patient we are going to do this procedure. And so the cooperation of the patient should be first taken, and then gentle insertion, then the patient will cooperate very smoothly. Then we have inserted, and we are introducing the catheter tube through the catheter. Then when it reaches the urinary bladder, it enters the urinary bladder, what happens is urine comes out and it will be collected in the urobag. That is what happening. If we are suppose sufficient length of the urinary tube has introduced into the urobag, even after that no urine comes out, then we should suspect that the sides of the urethral opening might have blocked with the wall of the bladder. Then we can turn the tube. If this tube is turned, then urine will come out. Then after it has reached the urinary bladder, then immediately do not inflate the bladder, do not inflate the balloon. Instead, advance a little more into the urinary bladder, because the balloon part is just behind the urethral opening. This is the urethral opening. The balloon part is just behind the urethral opening. As soon as the urethral opening reaches the bladder, urine will start to come into the urobag. And at the same time, this part, the balloon part, remains in the urethral passage, and so it should be introduced a little more into the urinary bladder. Then only we should inflate the balloon. To inflate the balloon, we should have sterile water. We will discuss why sterile water. Actually, it is not inflated with water, with air. It is inflated with water, sterile water. Why sterile water? We will discuss it later. This sterile water that is not having any contact with the interior of the bladder. Still, we should be very particular about the water should be sterile. A sterile water. How much amount of water is to be introduced? It varies as per the catheter type. Usually, it will be written on the head part of the urinary this catheter. How much amount of water is to be introduced? In sometimes it is 15 ml, 15 cc. Sometimes it is 20 up to 30 or 35. Usually, if nothing is written, then we can introduce 25 to 30 ml of this sterile water. Okay. When it is introduced, this balloon is retained, balloon is inflated with water, then even if we are dragging it, even if we are pulling it, it won't come out. That is why it is known as retained catheter. To pull it out, first what we have to do is that this balloon should be deflated. Then only it can be removed. Then inflate the balloon with sterile water. That is the procedure that we can adopt in a case of urinary catheterization. Then we should know, we should expect some complications of this Foly's catheter in the patient. That should be addressed when there is a issue. One is infection. Regarding the infection, we know it is a manual procedure. In this manual procedure, there is a possibility, even though we are adopting all sterile precautions, there are possibilities of infection in the in the urinary tract. Then another complication is bladder spasm, because actually it is a foreign material that is introduced into the urinary bladder. There's a possibility of the bladder to make this foreign body out, and so there is a possibility of bladder spasm. Another thing is that the retained catheter, it is unable to deflate. Once we want to take it out, we want to remove the catheter. Suppose when we have to remove it, we will discuss later. When the catheter is to be removed, when we are removing, the retained catheter is unable to deflate. This is another complication. We will address it later. Okay. Then, what are the causes of this unable to deflate? One thing is that malfunctioning of inflation valve. It is caused by external clumping or crushing. In this case, suppose this is the inflation. Inside this, there's an inflation valve, one-way valve. It may be damaged due to sometimes it may be damaged due to repeated manipulations. Suppose we have a syringe. This is a syringe which we have used for the inflation of the balloon. Then if we have to inflate with 30 ml of water, but we have got only a 5 ml syringe, then what will happen? We have to manipulate this small syringe 5 to 6 times manipulation. During the repeated manipulation, during the inflation, there is the possibility of this valve get damaged. If this valve is get damaged, it will be unable to deflate the balloon. That's the one issue. Then to prevent that, it is better to use a large syringe. It is a syringe with 20 ml syringe. If you have a 20 ml syringe or 30 ml syringe or 50 ml syringe, it will be very convenient. And we can do it, the inflation can be done with a single manipulation. That's one issue. Or sometimes another is a clinking of inflation channel. Sometimes this Foly's catheter might have kinked or crushed like this. Sometimes it may be beneath the body of the patient or under the bed, etc. This kinking of inflation channel. Another reason is that obstruction of inflation channel by crystallization. That is why we are we should be very particular about non-sterile fluid is used to fill the balloon. Suppose if we are using a normal water, a fresh water, the fresh water contains a number of microparticles. These microparticles there's a possibility of the microparticles to get adhered to the interior of the balloon or the interior of the tube. Then the channel may be blocked. That is why we already insisted that we should have a non-sterile water. If the non-sterile water, there is no possibility of adherence of this there is no possibility of micro materials in this water. That is why we should use this type of water. Then, suppose there is such issues, then we can manage it. How to manage? This management, one is advance the catheter to ensure that it is actually in the bladder. And then secondly, if after we have advanced the catheters till forward, even after that we are unable to deflate it, then we can cut just proximal to the this end can be cut, then water will automatically come out. If it fails, then the obstruction is likely along the catheter or the entrance of the balloon. If the obstruction is the entrance of the balloon, then we cannot deflate it. Then there is a stylet may be used. Lubricated fine gauge guide wire, that is known as stylet. A fine wire is available. If it is we are giving a small catheter in a children's catheter, a pediatric catheter, in a pediatric catheter, it will be supplied along with that, a stylet or a small fine gauge wire. That wire can be introduced through the tube, and as soon as when it reaches the tube, it will open, it will help to open the channels, and it can be removed. Then or the stylet. Then if then also it fails, then a CVC, that is central venous catheter, is passed over the stylet, then passed over the stylet, and then the stylet is removed, and the balloon can be deflated. These are the procedures. Even after all these procedures, we are unable to deflate the balloon. Then we should know that it can be done by using some mineral oils, about 10 ml of mineral oils injected through inflation port through the balloon, and this balloon is get dissolved. The mineral oils like chloroform, acetone, etc. either so can be used. But we should know this is the procedure, but we are not supposed to do this procedure because it is not our business. It should be done in a theater facility. And so if you are unable to deflate the catheter, we should with all these measures that we have taken, explained earlier, then it should be not our business. It should be given to a hospital where the surgical procedures or theater is available. Then they will manage it like using this mineral oil. Okay. Then these are the catheters that we have discussed. In the introduction we are told that there are 3 types of catheters. One is retained catheter, that is this Foly's catheter. Another catheter is that intermittent or Robinson's catheter. This catheter is used in, it is not retained catheter. It is not retained catheter. The other is Foly's catheter is retained because it is retained inside the body for a long period, up to 1 month in the case of rubber catheter, up to 6 months in the case of a silicone catheter. But suppose the patient do not need any long-term use of a catheter. Spontaneous or temporary need is only in demand. Then an intermittent or Robinson catheter can be used. The catheter is introduced into the urinary bladder, then urine is removed, and then it is dispersed. That is what this is, the intermittent or Robinson catheter. The patient himself can do this procedure. There is no need of a sophisticated equipment, and there is no need of actually there is no need of a medical professional. Even a patient himself can do this procedure, provided this Robinson's catheter is sterile, and some lignocaine gel or some like gel can be used, and then he can do himself this procedure. Then it can be removed within 5 to 10 minutes. Urine can be removed. Then another procedure, another catheter is condom catheter. Actually, this condom catheter do not satisfy the definition of catheter. Definition of catheter was the introduction of a tube into the urinary bladder through the urethra. But in the case of a condom catheter, this is a condom catheter, it do not is introduced into the urinary bladder. Instead, it is used in the males only, especially in the case of urinary incontinence, not in the urinary retention. Okay, there are three types of condom catheter. We should give the prescription small, medium, large. Usually the medium in the adult, small in the children. If there is any question of large, then we should give the direction for a large condom catheter. Okay, urinary incontinence in males is the indication of this condom catheter. Then this condom catheter should be changed daily. It should not be retained as such for a long period. But because there are some complications of this condom catheter. One complication is UTI after repeated use. Another, then injury to the skin, that is inflammation, necrosis, gangrene, because after it is introduced, after it is plastered over the penis, and there is a possibility of the skin of the skin of the patient is very delicate, and if it is retained or if it is too tight, there is a possibility of inflammatory signs. Then constriction of penis, it should not be too tight to the penis. Then suppose we have adopted all these measures. We have adopted, suppose the patient is having a retention of the urine, and we have adopted three types of, or first we have applied the hot and cold water application. Then the urine is not coming out. After that, we have opened the tap water. Even after it is not, urine is not coming. And the third condition, we have failed in introducing a catheter. Suppose there may be, in this case of a CA prostate, we are trying to introduce this urinary catheter. While introducing urinary catheter, we should be very careful in a case of a patient having CA prostate, because we should not give, when we are introducing the catheter in a male, at first there will be some resistance. After, once it has introduced, then it will not, there will not be any resistance. It will go smoothly into the through the urethral channel. Instead, if there is any hindrance, if there is any obstruction, do not force to introduce, because in the case of a CA prostate, there is the possibility of infiltration of prostate into the urethral channel. And if we are giving force, if we are giving too strong force, then there is a possibility of injury to the blood vessels, massive bleeding might have happened. And so be careful in a case of CA prostate not to give, not to force, not to introduce forcefully into the urinary channel. And so if we are unable to void the patient's urine after, even after we have attempted all this, or we are failing in the introduction of a urinary channel, then the next option is suprapubic cystostomy. If we are failing, that is not our business. It is the business of in a allopathic hospital where there is enough surgical procedures are there. These are the suprapubic cystostomy is the next option for deflate or for removing the urine. Then suppose we are using a Foly catheter for long term. There are the hospitals. We should know what are the complications of a long-term catheter usage. When we giving enough direction to the nursing staff, nursing personnel, we should know, we should be authenticative, we should be authoritative, and we should tell them on the platform of thorough knowledge why we are directing this and this, and what are the complications accepted in long-term use. UTI, and show that is why it is should be a last resort. Then another thing is septicemia. Then blood poisoning is also may be expected in a case of severe UTI. And then urethral injury during the procedure, there is the possibility of injury to the urethral passages. Then bladder stone, because the foreign material, the Foly catheter that is retained inside the body, inside the urinary bladder, that act as a nidus for the formation of bladder stones, and so it may lead to bladder stones. And very rarely there is a possibility of bladder cancer, even though it is very rare. Okay. Then, thank God for having a piece without a piece. That is all regarding the catheterization. If anyone is having any doubt regarding this catheterization, we can discuss that. If there is no doubt, then we can go to the next topic, that is nebulization.
If any of the doctors is having any doubt you can raise your hands so that I can unmute you. Sir, there is a question in the chat box: how to decide the size of catheter to be used?
Okay. Regarding the size of catheter, usually we use in an adult 12 to 16 size catheter is used in an adult. If there is no indicator, the first we are using, we can go for 12 size catheter. Hello?
And also one more question: how to select the size?
Yes.
Yes, sir. Yes, sir. Continue.
Yes, the size ranges from, in the case of a Foly catheter, the size ranges from 6 to 26 French size. Then, if it is the patient is an adult, then we'll go for 12 to 16 size. There is no much difference between this 12 and 14, and 14 and 16, 16 and 18. There is much difference between these. Only all in even numbers are available, not in the odd numbers. Then, if you are giving, if you are intending for the first time in a patient, a catheter for the first time adult patient, then we can select 12 or 14. If repeated catheterization, there's a possibility of dribbling of urine over the catheter tube. If there is a dribbling of urine, then we go for a larger size. Then if the patient is having under catheterization for a long time for the 12 size, then if there is no problem of dribbling or no problem of leakage of any urine, then we can retain in the 12 catheter. If 12 catheters is not available in a shop, then we go for 14 catheter. That is very small difference is there. Then if the patient is having in certain cases after repeated use or the certain diseases of the penis, there is dribbling, very fast dribbling or profuse urine comes out after catheterization, then go for 20, 22, 26, etc. But it is not usually needed. In the case of children, in the case of especially in the case of infants, 6 to 8 is enough. In the case of children, 10 to 12 is enough. That is the size of catheter where we are usually selecting. Another question? Suppose one more thing I have forgot to tell is that when we introduce a catheter into the urinary bladder, bear in mind that the length of the male urethra is about 20 centimeter. The length of a female urethra is 3 to 5 centimeter. We should bear in mind that. Suppose actually introduction of a catheter is very easy in the females because the length of the urethra is very less. Only the problem is to trace the urethral opening. Once this opening is traced and it is found out, it is easy. Then in the case of male, it is about 20 centimeter low. That should be beared in the mind, because after we have introduced into about 20 centimeter, then even after that, if the urine is not coming out, then we should think of other questions. Why the urine is not coming out?
Sir, there is one more question. Can homeopaths have right to do catheterization? Is it okay?
Actually, what is peculiar for an allopath is not the management part. It is their therapeutic part. Management part is not exclusive for any system of medicines, any school of thought. It is general principle, because suppose a patient is having dehydration. A dehydrated patient should be supplemented water. If he is taking water orally, it is enough. If he is not taking orally or is unable to take orally, then it should be supplemented. It should be supplemented either by IV methods or by Riles tube, the nasogastric method. It is applicable to every system of medicine. It is not exclusively for any system, peculiar to any system of medicine. It should be understood at first by a homeopath.
Pediatric size catheter.
Okay, that we have mentioned earlier.
Size of the pediatric catheter.
Pediatric
Already
catheter,
mentioned. Okay. How to retain bladder function after prolonged catheterization?
How to
retain bladder function after prolonged catheterization?
Even after prolonged catheterization, the catheterization, the indication of the catheterization we have discussed earlier. Once the indication is resolved, then we can remove the catheter. With our medicine, in the allopathic hospital, the patient is under catheterization for a long period of time, for years. But in our hospital, what happens is after 1 or 2, 3 months or 4 or 5 months, then our medicine, the patient is under our treatment. Then the patient is will be very happy to have a good position, normal urination. The issue will be resolved. Then there is no need of catheterization anymore.
I think we can continue to our next session, as we are already running out of time.
Okay.
You can continue the next session.
Okay, next portion we are going to discuss regarding nebulization. Nebulization therapy. Many doctors or many medical attendants thinks that nebulizer gives hot water or heat. Nebulizer gives heat. Actually, it is not heat or steam. That's a nebulizer is not actually heat. It is a machine. A nebulizer is a machine. It administers medicine in the form of aerosol. What is aerosol? The aerosol is a mixture of air and water, gas and liquid particles. That is an aerosol. Actually, a nebulizer administers medicine in the form of aerosol. Gas plus liquid particles. Our medicine is in the liquid particles, that is usually dissolved with normal saline or sterile water. Then it is passed, a high velocity of gas is passed, and this gas and liquid are mixed and it is introduced. That is the nebulizer dose. The best example of aerosol is mist. Mist is a natural aerosol. Then aerosol is a mixture of gas and liquid particles. Then what a nebulizer do is that it generates compressed air at high velocity and is passed through the medicine, and it is turned into aerosol, a mixture of gas and liquid particles, and it is inhaled the patient. And so these inhaled particles that contains minute medicinal particles directly reach the lung system, and so there will be immediate relief to the patient. This is actually the compressor, nebulizer compressor. We will discuss the parts of a nebulizing machine. The particles that is introduced as a nebulizer has got 3 types of particles regarding the size. More than 10 millimicron particles will be generated. Some portion of the nebulized particles will be more than 10 millimicrons. It is deposited between mouth and throat. It is not useful for our medication. And then between 5 to 10 millimicrons, it is deposited between the mouth and lung. Less than 5 millimicrons, that reaches the lung tissue. Less than 5 millimicrons, it is deposited in the lower airways. And then that is suitable for their medications. The quality of a nebulizing machine depends on how much quantity of less than 5 millimicrons are produced. That is the quality of this nebulizer. If the nebulizer produces only more than 5 millimicrons, there is no use of this nebulization, and so we should have good nebulizing machine. That is important. Then what are the indications of a nebulization? One is cystic fibrosis. That we know, in the case of a cystic fibrosis is a inherited disorder. And in the case of cystic fibrosis, what happens is in the lung tissue, the mucus will be very thick, and instead of it get diluted, it will be very thick and very stringy form. It will be clogged. It will be clogging the airways and the lung parenchyma. And so cystic fibrosis in the case of cystic. And another indication is in the case of asthma and COPD, chronic bronchitis and emphysema. In these conditions, we will get immediate relief to the patient as when we use this other respiratory diseases. Also, these are the indications for nebulization. In these cases, we have wonderful medicines. Even after having our medicines, there are certain aggravations or acute exacerbations may be expected, especially in the night. During the period, the patient gasps or breathe, and during this time, we can perform a nebulization using the nebulizer. Then, what are the purposes? What happens during the nebulization? It increases sputum expectoration. The sputum that is thick in the respiratory passages get the sputum expectoration is increased as a part of period. Then reduce difficulty in breathing. Expectoration, much phlegm is breathed expected out, then the patient will give a good relief and difficulty of breathing may be lessened. Then it increases the vital capacity of the lungs as well as the patient. Then nebulizer, the parts of a nebulizer, main machine, that is the compressor. This machine that is known as the compressor. This is the compressor of the nebulizer. Then air filter are there. This is nebulizing cup, this is nebulizing cup. Then there are different types of adapters are there. Then there will be a connecting hose, then mask, different size of mask, the children's mask and adult mask that you all know. These are the part of a nebulizing machine. Okay, then the medicines used for nebulization. Which medicine can be used and how it is used? Suppose this is the nebulizing cup. In this nebulizing cup, this is the cup. In this cup, take 5 ml of normal saline. Use normal saline always. If the normal saline is not available, then we can use distilled water also. Take 5 ml of normal saline and then take little amount of indicated medicine. Then do not take large amount of medicine. 3 or 4 drops is enough for a nebulization. 5 ml of normal saline in this jar, and then 3 or 4 drops of indicated medicine. That indicated medicine give good results in the case of nebulization. Don't use blindly this medicine or that medicine. The indicated medicine what we are using for nebulization, one is Blata orientalis. Then we know it is used in stout patients with the cough, with dyspnea, pus level. That in the case of, especially in the case of bronchitis, we are using Blata orientalis. Another medicine is that can be used for nebulization is Grandilia. In the case of asthma or chronic bronchitis, the mucus is very tough, as in the case of cystic fibrosis, it gives good result. In cystic fibrosis, Grandilia gives good result. Then smothering after falling asleep, that we know the symptomatic. I don't want to go to the symptomatology, but just a brief description. Then another medicine that can be used for nebulization is Lobelia inflata, especially if there is a gastric derangement, asthma with nausea and vomiting, senile emphysema. It is used especially in the case of an adult symptom is the patient is having light completion flushing people. Then another medicine is Ipecacuanha, that we know with persistent nausea or violent cough, especially if the patient is having a clean tongue or mildly coated tongue, that's an indication of Ipecacuanha. Then with the constrictive feeling of chest, like in the case of cactus. Then violent suffocative cough with during breathing, and very difficult to get the phlegm. The chest seems to be full of phlegm, but nothing expectorated, and this condition Ipecacuanha. This tincture is not very important, but especially tincture may not be used. Instead, I use Ipecacuanha 3x. It gets more result than tincture in my experience. You might have different experiences. That's also welcome. Then pathos foetis, especially in the allergic asthma, aggression of dust, peculiarity of peculiar symptom. Asthma ablated after stool is a peculiar symptom of pathos foetis. Okay, then aspidosperma, the digitalis of lung, especially in the cardiac asthma, it gives good results. It stimulates the respiratory center and increases oxygen in the blood also. Aspidosperma is wonderful medicine to increase the vitality of the lung tissue. Then rhodoctone is another important medicine in chronic bronchitis, asthma relieved by expectoration. The emaciated individuals, night sweats. In the case of pulmonary tuberculosis, rhodoctone gives. If the patient is having pulmonary tuberculosis with chest infections, and he is having difficulty in breathing, unable to expectorate, rhodoctone gives good results. Then aurelian rosmosa, light on aggravation, night sweats. Then sensation of a foreign body, in the throat. That is an important feature of Aurelia. Then frequent sneezing. Also, Aurelia is also like pathos foetis, allergic asthma. Aurelia gives also good result. Then that is all regarding the nebulization. If anyone have any doubt, you may raise.
One question. Any potency of the indicated medicine can be used or in tincture form for nebulization.
Please once more. It is not clear.
Which is to be used?
What?
Potency or tincture?
Actually, we are using in the case of nebulization, we can use if it's very indicated medicine. Suppose a patient is an arsenic patient. If an arsenic patient, we know that is an arsenic patient, a constitution is arsenic, we can also give arsenic 30, 1 drop in nebulization. It also will give good results. Arsenic in the, especially in the arsenic, don't go for low potencies in the arsenic, because in the low potencies the 3x is available, even arsenic tincture is available. Don't go to the tincture, especially in the arsenic, because it contains the lethal particles in the arsenic. But in the other medicines, we can use the mother tinctures if we are sure that the patient is a grandilia patient, or if the patient is a another bladder patient, we can go for 30 also. If we do not get the third, if the patient is constitutionally such a patient, then we can go for 30 such potencies. If it is not, then go for lower potencies and tincture, because this tincture gives temporary relief. But if you are giving the nebulization with indicated with very minute quantity of medicine, it will also give general relief to the patient, not only to the acute condition, it will give general relief to the patient. That is our experience.
How many minutes we have to use nebulization?
How many minutes?
How many minutes? How long can be used?
We cannot restrict the minutes. Instead, how long we used is to be decided by when the patient give enough relief. Suppose we should during the procedure, we should ask the patient to inhale deeply and to hold the breath and to exhale. When the patient give enough relief, then we can remove. This removal may not be at a time. Instead, we can frequently give 3 or 4 times of for 3 or 4 minutes of inhalation or nebulization. Then we can remove. Then ask him to deep breathe and expectorate. Then much quantity of phlegm can be expected, he get relief. Then again we can again give the nebulization, then we will get some more relief. Then that is how we can determine the time period depending on the patient's relief and also the patient's suffocative attacks.
Sir, one question, is it safe to use nebulizer in infants just for the normal cough and coryza, which is done frequently by the allopathic doctor nowadays?
We are not supposed to use like allopathic. They are giving vasodilatation or bronchodilators. We are not using actually the bronchodilators. These bronchodilators will temporarily will expand the bronchi and give relief. Usually, our medicine itself will give wonders in the case of infants. If it is not giving, if then suppose we are giving a correct medicine, it will give result, the relief of the patient's distress in a 10 minutes or 15 minutes. If it is not getting, or we are unable to come to a correct medicine, then in infants can be nebulized using indicated medicine, provided the medicine should be very little quantities should be used. Not suppose if in the case of an adult we are using 3 or 4 drops, then in an infant we should use only 1 drop. That should be, we should manage it in an infant.
So next question, how to sterilize the nebulizer after use?
Nebulizer should be sterilized using this antiseptic solution. This not sterilized. It is antiseptic. Antiseptic solutions are used. It is wiped using an antiseptic solution. No need of sterilization. Only disinfectant may be used. Disinfection is enough. No sterilization is needed.
Can we give homeopathic medicines along with? I think the question is regarding taking internally.
Yeah. What? What? Not clear.
Is it safe to take the medicine internally along with the nebulization?
We nebulize once the patient is not getting enough relief after the administration of an internal medicine. We are not going to first the nebulization. Before that, we are giving a medicine and we wait for 10 or 15 minutes. Then we are not getting the enough the expected result. The patient is not having any relief of the complaints. Then we are going to nebulization. After nebulization, the patient gets relief. Then we can go to our medicine internally.
So there are some questions regarding the price of the nebulizer. Should we use separate mouthpiece for every patient? Can the mask be reused?
The mask can be reused
I
after
think such
disinfection. The only disinfection is this mask is not disposable. It can be used for a number of patients provided. It should be disinfected, not sterilized. Only disinfection is needed. You may be aware of the difference between sterilization and disinfection. Sterilization means the disinfection or to destroy all the organisms, irrespective of the pathogens or non-pathogenic organisms. But in the case of disinfection, we are destroying only the pathogenic organisms. The non-pathogenic organisms are retained, and it is not needed to suppose only disinfection is needed using a disinfectant solution. A Dettol solutions can be used, or Savlon solutions can be used, and so it can be wiped using a solution, disinfectant solution. No need of sterilization.
Sir, there is a question. Ask you to show the medicines once more. The medicine used for nebulization.
Okay. The medicines are one is Blatta orientalis. For the detailed description of the medicine and differentiation, go to the Materia Medica, especially boric Materia Medica. Blatta orientalis, another is Grindelia, Lobule inflata. These are usually used in tincture form, and 3x is also available. Then Ipecacuanha. I got good result Ipecacuanha 3x, not in the tincture form. Pothos foetidus, Aspidosperma, Rheodiction, Aurelia racemosa, these are the medicines usually used. Justice
Sir,
also
any
will get a good
complications
result.
in? Okay. Any complications in doing nebulization, especially in infants?
The complication in inflammation we are doing for long periods because the complication, the quantity of medicine is increased, long period nebulization, and if you are using non-sterile medium for the introduction of this medicinal particle into the lungs. These are the cause of the complication. Because suppose in certain hospitals also, they are using the tap water for the nebulization. Even the patient's lung itself is in a diseased condition. Then if we are introducing the tap water, it contains a number of pathogens. Then it is loaded, if it is loaded, this lung is loaded with this type of water and organisms. What will happen? We can expect. There is a possibility of complication not only in the infants but in adults also. And so during the to avoid the complication, use only the little amount of medicine, use only normal saline free of pathogens, better normal saline, because it is in consonant with our body fluids, and then don't give too much time. Too much of nebulization should not be administered. Then there is no complications.
Dr. Amsal?
Sir, one more last question. I think we can removal of catheter after the death of the patient.
Yes.
That will be the last question. Removal of catheter after the death of the patient.
We have already discussed how to remove the catheter. To remove the catheter, even whether the patient is dead or not, it is the same procedure. Suppose the patient is dead, we are removing the catheter, we are deflating the balloon using a syringe. When we are going to deflate, we should keep it a syringe. A syringe is used to deflate the catheter. When it is deflated, then this balloon is deflated, and after deflation, we can withdraw, we can pull the catheter very smoothly. No hindrance is there. Why the catheter is not coming out before we are deflating is that this balloon is swollen and it is retained, and that is why it is not, we are unable to pull it back. Instead, we are pulling the water out, deflating, then it will be easily removed. Suppose in a case of dead case, this syringe is not available, then we can cut this portion proximal to the covered area. This part can be cut. If this part is cut, the valve is situated inside this portion, then this part is cut, then water will automatically, due to the force of water is inside the balloon is more, and so water will escape out, and then we can remove it. That's what we are usually doing.
I think we can conclude the session. Almost all the queries are already answered.
Okay, thank you.
There is one more presentation by Dr. Joyce. So on behalf of IHMA, I express my sincere gratitude to Dr. Abdu Rahman
Actually, the voice is breaking.
for the wonderful session today. Although we had some technical glitches in the last classes, we have completed without any difficulties. Sincere thanks to Dr. Abdu Rahman and all the participants.
Thank you for providing such a wonderful platform for presenting this session. Thank you all.
Okay.
Dr. Joyce, can you take on?
Hello. Yes, Dr. Deepu, hope you have finished the session. Like one case presentation, right?
Yeah.
So
I think some disturbance. I will make him Neeraj, I think.
okay, we can't see him in the host portion.
Neerav Ganga. Okay, make co-host. Okay. Neerav, just wait. Make co-host.
Yes, yes.
Dr. Nirav, you can share the screen, okay?
Okay, sorry. You need to remove this screen right now, so
No, no,
I
no, no.
can.
No. You can share the screen, then it will be removed, okay? You can share your screen, no problem.
Can you see my screen right now?
Yeah, it is coming. Then can you share your screen one? Yes, it's okay now. It's okay now. Okay, you can go.
Yeah, it's visible, Dr. Nirav. You can continue.
Okay, sir. So, my case presentation is to demonstrate that home is kind of central, rapid, and permanent. I'll demonstrate it by having an insight, or I can by the case presentations of the urinary tract infections. Generally, here homeopathy is the science of is very slow science, and we cannot get a speedy recovery in the through homeopathic. For that, I'm going to present the cases which were
Dr.
long
Nirav,
standing and having a recurrent UTI. But were, yes, sir.
are you using a
Am I
mobile phone
audible?
or laptop? It's okay. I think you are using
Yes, I
your
am using
network.
a mobile phone.
Okay. There's some kind of
Yes.
voices are breaking. It's okay. You can continue. Okay.
Okay, sir. So generally, we have heard about that. It takes a long time, and it takes very, you can say, time for getting healed or cured by homeopathy. And for that, I'm to present the UTI. Generally, it is an inflammation of urethral to the bacterial invasion. This generally expressed with bacteria and pyuria in the reports, laboratory investigations generally. Am I audible to you?
I some technical problems are happening. Doctor, can you just put your phone on any side and you can talk? Okay. You just don't
Yes,
keep that in your hand. Okay. Just place that anywhere. Okay.
Now am I audible to you?
Yeah, it's now okay. Okay.
Okay, so urinary tract infection is generally an inflammatory response and by our urothelium, which is generally expressed in the way of bacteria and pyuria. Bacteria means that we can see the presence of bacteria in the urine, and pyuria is the first cells, that is the white blood cells which we can see in the urine. So it expresses about the urinary tract infections. UTI is a very serious problem, but it is seen commonly as in all the age groups. Millions of cases we can see of UTI. UTI generally involves the different parts. It can involve the kidney region. It may involve the bladder and urethra, and according to it, how the area or the region which is being infected, we can name it like acute pyelonephritis. Then we can see if it is long standing, then chronic pyelonephritis. If it is affecting the bladder region, then we can say it is cystitis. If it is the urethra which is affected, then we can say that it is urethritis. So according to it, and other classification which we also can have, that is isolated infections, that it is not getting transmitted to the different regions or contaminating unresolved infections, that by the medications the sign and symptoms are getting removed, but the culprit, the bacteria, are still present in the urinary tract. and it is also again causing recurrent UTIs, which are reinfections, and it may metastasize or it can transmit to other parts through different routes like direct route, blood route, metagenous route, or the lymphatic route, and recurrent infections resulting from the bacterial persistence, which is we saw in the second cause. Now, if we see the miasmatic background of UTI, it is being manifested in all the miasmatic in manifestations like storic manifestations, psychotic, and as well as on tubercular portions also. So, miasmatic background, if we see, then Master Henneman already has explained regarding to storic manifestations that if a person having a storic UTI infection, then at times, too much urine is discharged, which is succeeded by great weariness. That is, the person is having a painful urination, which makes him exhausted and very weak. Pressure on the bladder is getting created because it is having a functional disturbance. So, person cannot hold the urine for long period of time, and if it's getting holded or if it is having any persistent urinary disturbances, then at a single paroxysm of cough, or while laughing, or while sneezing, it gets pass off. So due to the functional disturbance also this can be happening. Then we have frequent mutilation at night. We have whitish urine with sweetish melanges, that is the due to disturbance in the metabolism of nitrogen, which can be reflected in this UTI. These are the storic manifestations. Next, we see we have the tubercular manifestations and of the psychotic manifestations. The tubercular patient has the complaints of anxiety and loss of strength. That is, they cannot bear their weakness during this UTI problems. Then, in again, if we see in the tubercular patient, the most prominent is sodic instead of syphilitic. When it gets with syphilitic, then we can have bleeding and all the urine with reddish discoloration, which we see in lycopodium. But now we see about the psychotic element, then there is very painful urination in psychotic people because at that time we can also see some pathological disturbances due to the overgrowth which can be seen in urinary tract due to the psychotic element. Psychotic patients may have painful spasm in urethra and bladder also because the muscles which get contracted or which may have overgrown due to the psychotic change in it. So others we can see the gouty concretions also we can see like that in lycopodium we have red concretions. In other remedies we have white concretions like osmium and all. Patients come under the tubercular or pseudosoric miasm with offensive urine. So offensiveness is marked in these patients. Next is a few homeopathic remedies which are very common for the cases of urinary tract infection. That is Apis mellifica, Cantharis. Apis mellifica is a very wonderful drug for UTI because the main persistent symptom that is of burning and the urinary tract infections or urinary troubles related to Apis. Cantharis is there also nitric acid for the patient having syphilitic UTI. Staphycaglia for psychosyphilitic elements. Lycopodium when it is having a spasmodic pain and red sand in urine which you can see during the micturition and when it is hold standing. Then we have Berberis vulgaris, hydrangea, Popaiva, terebinthine, equisentum, benzoic acid, cannabis indica also, but it is not listed here. But we have a persistent UTI in which the patient is having very burning sensation in urethra and patient cannot hold the legs together. So these are the few homeopathic remedies for UTI. Now I'm coming finally on the case presentation, which will demolish all the beliefs regarding the homeopathic science that it is solving the troubles very lately or is taking very much time for resolving the problem. So I had got a patient, a female patient who was recently married, and she had this problem from when she was not married even also because of those longer period of time, near about 6 to 7 months, when her marriage was fixed. From that particular portion of time period, she was having this complaint. A recently married female came to the clinic with her mother-in-law, and she had complained. She was a lady really from the lower background, and she know about Hindi, so I have mentioned that it in patient's language itself. She said that शायद बाथरूम जाते वक्त बहुत जलन होती है, दवाई लेते हैं तो ठीक हो जाता है, पर वापस से हो जाता है. And on proper case checking, I have elicited the chief complaints of this lady, which is shown in the next slide. But what she wants to tell here is that she is complaining that when she is going for urination, she has very much extensive burning. And if she takes the medicine, that is generally the antibacterial medicine, she gets relief, but again and again she is getting this problem. So finally, she ended up to the homeopathy. So this is the chief complaint which I, on the case taking, I have elicited. Location I have mentioned it as GUT and especially the urethral portion. On the how complaints that after urination it is burning, so I have tried to elicit it is up to urethra. The sensation she described that constant ineffectual urge. In further slides, I have also mentioned this thing that she says that एक बार जाती है तो वापस जाने का मन होता है. That is, she is not getting satisfied by one urination. So she needs to go continuously and has urge for urinate again and again. When she is urinating, she has burning pain in urinary tract, and after passing the urine also she is burning. And this burning is very much extensive for the patient because this was observed when she described this type of this complaints. And she has dribbling of urine. That is, she says that कभी कभी ऐसा लगता है कि the her underwear has got wet because whenever she tries to urinate or whenever she is walking also, if she gets cough and all, then she is getting urination. Pain persists even after she has urinated, and even she is not passing urine. Afterwards, when she gets urinated, then also the pain gets persisted. Modalities in mental, we'll see about this anger and all, but if during the urination or if she's touching her parts, and then also it get aggravating. And during urination, after urination, and amelioration is getting when she is giving hot fermentation to that region. And if she's resting and if she has total mental calmness, then there is no complaint. Concomitantly, she has that headache which is having sensation of ball in forehead. That is she explained it as कि ऐसा लगता है कि दिमाग में किसी ने वो फुटबॉल रख दिया हो. That is, heavy ball has been kept. So this way she explained her all the complaints, and I have framed it as chief complaints as location, sensation, modalities, and concomitants. Then I took the history of her present illness, and she said that she had suffered many a times about this burning urinary tract infection, and I asked that till when, and she said that till from 8 months she is suffering from this problem because before 8 months everything was regular. Then why she is suffering from this 8 months itself? That came on in the later part when I investigated about her mental complaint. And on suggestion of her neighboring aunt's good experience of our homeopathic science, she chose for this homeopathic treatment. The lady complained that after urination there is severe burning and she feels every now and then that she needs to go to washroom, that she has lack of you can say control over her urinary organ. She feels that sensation as if urine is present inside and rolling up and down. And she complained that pain worsens after she completes the urination. And she complained in her vernacular language that एक बार जाके आती हूँ तो फिर भी ऐसा लगता है कि वापस से जाना पड़ेगा. That I have mentioned in the LSMC portion also, where she says that even after urination she needs to go for urination. She feels that she want to go for urination. And associated complaints she has told about the headache which she has especially in the forehead and having sensation of ball. And she says when I asked about her modalities that how your headache gets relieved, at that time she says that when if I sleep down closing lights and having leaning over the head, or staying like, or leaning over the pillow and sitting erect also. Just what I observed, that she wanted that leaning her head over the pillow, because while sleeping also she wants a leaning over the head. And she said, if I sit on chair also, I need my head to be bent backwards and lean over the pillow. At that time, I asked for the confirmation, because we have again modalities in repertory, that leaning over the pillow amelioration and also bending back head amelioration. So for differentiation, I asked that if you don't use the pillow, then is it okay? Then she says, no, I need pillow. I need the softness of that pillow, which ameliorates her headache. So this was about her present complaints and the associated complaints. Then I investigated about the physical generals. At that time, she did first is 4 to 5 glasses in morning and 1 to 2 glasses in night, and she needs to wake up for drinking water. She feels thirstless at night. Then urine was having burning micturition and desires for sweet, aversion to cheese and almost all the fatty food. She's having sweating, which is normal, and dreams she has amoral. Sleep that is sleepy all day and awaken at night. So these were about the physical generals which she has told. Now the main portion, that is of mentals, which is the explorating tool of my this case. When the daughter-in-law came with her mother, when this lady came with her mother-in-law and was sitting with her, she was very mild, and with gentle smile she was replying all my questions. Whatever I asked, she was like a lady which is having very much sincerity in her behavior, and everything is all fine, and just always replying with a sweet smile. During the case taking also, mother-in-law also said that ये मुझे ये बहुत ही सर्वगुण संपन्न बहू मिली है. That means her daughter-in-law is totally all fine, and she is expertise in all the fields. And on listening this also, the expressions which I marked on the young lady's face were very happy, that she was feeling like, yes, my mother-in-law has appreciated me. But if everything is going fine, there is something fishy in the case. So I told the mother-in-law to sit outside and interrogated the lady in absence of her mother-in-law and with both of the ladies' consent. The moment the mother-in-law went out and I asked that briefly or brief out about your complaints, she started crying like anything and said, "Sahib, मुझे मेरी सास और मेरी जेठानी से कम रखती है." That means she was feeling lower because she feels that her mother-in-law has more affectionate for her elder daughter-in-law and not for her. All the work she does, but still that mother-in-law needs or accompanies or privileges are given to her elder daughter-in-law. So due to all these things, she feels lowered down and she is having lack of willingness. Then after I asked her, what is the expression of this thing? She says that I don't feel good. But what do you don't feel good? What is the problem with it if you are getting this ill-treated? What is the reaction of your this ill-treatment? Then after she says that she feels very angered that I am doing all the things, but still that one, the elder one is getting all the appreciation and privileges. But still she doesn't fight because she feels that now this is my place, my home is this home, my home is now my husband's home. So she ignores everything, but that anger still is remaining inside her. That I am not being privileged, I am not having everything, and lack of will results into expressing her anger. She doesn't expresses her anger because of this lack of will. Now, after the whole case taking, I took this understanding about the case that before I sent mother-in-law outside, the mother-in-law was appreciating that lady. That I have got this girl is very perfect in all the manners. But still, that lady feels that she is not being treated well and suppresses the anger. Moreover, also she said that her husband remains out of the station and she can't do anything. So there is suppression of her sexual desire also during her case. So on these all the case, I found out the following symptoms which I should be considering: that she feels she's not treated properly or treated unjustly, suppression of her anger, and having the headaches and all the oppressed feeling in the chest and the head when he's getting angered, suppression of her sexual desire, burning pain. Of course, that is the main question in her problem. Ineffectual urination with sensation of urine present in the tract and heaviness feeling in the bladder. Headache as if ball is present in the head and need to lean it over something. Also, if we see again the physical generals and not only the mental generals, we can see that she is having aversion to cheese and almost all fatty food. Dreams, she's having some amorous dreams. And sleep is sleepy all day and awaken at night. So this also suggested towards a particular group, that is the ranunculus group, where we can see all these kinds of symptoms. That is pulsatilla, which belongs to the ranunculus group, aconite, Staphysacia, ranunculus bulbosus. All these have these similar kind of symptoms. That is aversion to cheese and almost all fatty foods, amorous dreams, sleepless nights, and due to all these problems, having the suppressed anger and all these questions, and having this mental understanding also, I found that I need to give her Staphysacia. So on the basis of these all the symptoms, I gave her only single dose of Staphysacia 1 m and was asked to come after 4 days. Just wanted to see whether this urinary trouble has only not only the urinary trouble but her mental symptoms also. Because we know that if the remedy selected is similimum, then it is going to act as soon as possible. So I asked her to come after the 4 days, and on the day when she came to me before also, because having some form related procedures. So at that time also, listening her complaint, she was asked to do or carry out the laboratory investigation. So her laboratory investigation before this prescription was shown. You can see over the screen that there are RBC also present. There is presence of pus cell. RBC presence, that means that this case belongs to the syphilitic miasm, and the remedy which syphilit is the remedy which has been chosen, that is having the syphilitic taint. That is the Staphysacia is having the psychosyphilitic taint in it. Then after we have the pus cells, that is in evidence, that is evidencing the presence of urinary tract infection. Also, the epithelial cells are present. So it was having a load of these all things. Also, the appearance of the urine was seen turbid, and all these suggested about the UTI, and Staphysacia is a very good remedy for UTI. And especially it is known as the honeymoon remedy or honeymoon cystitis. Remedy for honeymoon cystitis, that is the lady is having all the problems which has been related after the her marriage. So all these things were favoring the selection of the remedy. Then after I called her for follow-up, the first follow-up she gave, she said that on the next sitting itself, after the single dose of Stepi, she said, साहब जलन कम हो गई है, गुस्सा बहुत अभी नहीं आता है, और जेठानी और सास के साथ अच्छा तालमेल हो गया. That means all the complaints which were related to or which were due to the her being treated ill-treated or unjustified by mother-in-law and getting more privileges to her elder sister-in-law, she was getting all those troubles relaxed. And the burning, which was the persistent from so long, was also getting decreased. Again, one dose of Steffi was given with all the Seclec, and was asked to come out for the follow-up, and was asked to give the or was asked to conduct the laboratory investigations. You can see in the next slide where the urine analysis shows that the turbidity has been decreased. That is, it is almost appeared clear. RBC are absent. There are very few pus cells present. There is 2 to 3 pus cells only present. Epithelial cells are absent now, and this report has been done on the 13/12. You can see the first report. It was done on 5/12. It is on the 5th of the December, and only after 7 to 10 days, she has been got well from the urine analysis. That is on the 13/12 we can see. So with this case, I want to just express my conclusion, that is, acute illness are also treated with homeopathy in very speedy manner. It is a self-limiting disease. The acute illness is self-limiting disease. But due to the maintaining causes, the exciting causes, in our case, the maintaining cause was the ill treatment by the mother-in-law and the more privilege on the thought himself. Here, it might be there that the elder sister-in-law is not getting the privilege or not getting the more treated well than this one, but it might her thought that it was leading to her anger, her suppression of those anger. So these type of maintaining causes and exciting causes makes the acute illness resulting into chronic one. But if this causes, or if the treatment is given properly, that is our homeopathic treatment, which is considered to be the best one, then all these kind of causes can be treated, and that acute illness can be reverted back to the state of health. Here we can see that symptoms were having a rapid onset, and these symptoms are fairly intense and resolve in short period. Homeopathy is very precise science, and we all assume that our own individualistic symptoms during an acute case and treatment for this are also taken into the consideration. So, as the chronic diseases are treated by homeopathy, the acute ones are also treated as efficiently, and astonishing results are also obtained in acute ones also. Homeopathy takes longer time to cure is probably a myth, and if a remedy is selected holistically, that is on the basis of all the cardinal principles of our homeopathy, the time period is not at all the hurdle in the path of cure to the patient. So in conclusion, I want to say that homeopathy works better for acutes as well as for the chronic maladies with equal efficiency. In both the cases, it treats very efficiently. And last, I am highly thankful to Indian Homeopathic Medical Association, that is Kerala of Kerala State and Hope, for providing me such a wonderful platform to explain and provide my understanding to all my colleagues. For And also I am thankful to Deepu sir for coordinating very nicely. Though due to this technical issues, I am able to deliver my presentation very efficiently. Also, I would like to thank our respected principals of my college, that is Rajkot Homeopathic Medical College, affiliated to Parul University. That is Dr. Mehta sir, who has always motivated and supported all the faculties of RHMC, President sir of our Parul University, Dr. Devanshu Patel sir, and last but not the least, a very big thank to all the listeners for patient hearing. Thank you very much all for hearing and evidencing my case presentation. Thank you. Thank you, Deepu.
Thank you, Dr. Nirav. You could explain it in a very systematic manner. Thank you for the good explanation. So now we are winding up the session. Before that, I would like to conclude again with thanking Dr. Shardul Joshi, Dr. Nada, and Dr. Nirav for your case presentations. And of course, Dr. Abdu Rahman for sharing his experiences. And that was a very practical session. So now we have a very important announcement. We have IHMS upcoming dream program, that is IHMS Hope Online CECP, Competitive Examination Coaching Program, which starts on July 1st. This is meant for students and doctors who are preparing for PG examinations. So we'll be having further updates of this session that will be announced in the Telegram group. Participants, please stay updated with this. This is a dream program of IHMA and it will be happening from July 1st. So with this, we end up today's session and the webinar free series of Hope. Thank you all the participants for your wonderful cooperation and all the faculties. Once again, thanking you all. Good night. Dr. Deebu,
I'm
hope
here.
we can wind up the session.
Yeah. Actually, the main those who are interested will get a notification on the WhatsApp as well as in the Telegram group. So, and we are also continuing the webinars and workshops and need your support from there. We are just taking a small break and we will be back in next Sunday. Okay. Thank you.
Thank you, Dr. Deebu. Good night.